All right. Good evening or good afternoon, depending on where you are, ladies and gentlemen. Welcome to episode 11 of the Fleri Care Digest. Today, we have the pleasure of being with Francis Osiemo, CEO of SASA Doctor, a Kenyan telehealth provider that is paving the way and increasing accessibility to healthcare for Kenyans. We are also very happy to be joined by Lucy Harshon, a global healthcare consultant, expert in um, uh, emerging market healthcare, who's done amazing work across the World Bank with several healthcare organizations across Africa and Southeast Asia. She's joining us today as our guest. And together with myself, Sam Badu, founder and CEO of Fleri, we are going to be diving into the opportunity that telehealth, specifically from SASA Doctor, is creating in Kenya. Thank you all for being here. Lucy, it's a pleasure to have you here. Francis, thank you so much. We'll start with Lucy. Maybe you can give us some background into your work, how it connects to the global healthcare market. And Francis, you can also go ahead and introduce yourself. Thank you.
Sure, I'll go fast so we can hear from you, Francis. Thank you, Sam, for having me, and it's a pleasure to be here. My experience has been working with health systems in emerging markets to better understand and figure out how we can deliver high quality care to everyone who needs it, be it in the clinic, in the city, telehealth, or through online consultations. So really excited to be hearing from you, Francis, about all of your great work. Over to you.
Right. Thank you very much, Lucy and Sam. My name is Francis Osimo. I'm co-founder, co-CEO of SASA Health Limited that runs the SASA Doctor Medical Clinics that are both virtual and physical. And I don't think I'll dive in right away, but SASA Doctor is basically a healthcare company. We regard ourselves as a healthcare company that tries to deliver healthcare in Kenya through a platform, which is our application through telemedicine and also through physical clinics. We know telehealth is part of the ecosystem. It's not the whole ecosystem of the healthcare. It's part of the ecosystem that makes healthcare affordable and accessible at the same time. We know that there are bits that we can use telehealth for, and there are bits that we cannot for healthcare that we cannot use telehealth for. So the bit that we can use telehealth for is over 60, almost 70% of the common conditions that we go to hospital for, and that makes it part of the healthcare system to be able to improve delivery of healthcare services in underserved communities and in countries like ours.
So, Doc, thank you so much for the introduction. And it's important to state today is the first time we're having two co-hosts on the program, and so you get to be a guinea pig. You get to be bombarded from left and then right. I should have slotted you right there in the middle, but I hope you enjoy the process. You know, as you talk about telehealth. Often, the definition of telehealth could mean different things to different people depending on where they find themselves. For some people, telehealth could mean virtual care that is accessed over a mobile application. For other people, it could mean virtual healthcare that is accessed over a telephone, right? I'd like for you to explain when you talk about SASA Doctor and you talk about the telehealth that you provide, give us a background into what mechanism you're delivering healthcare through and how people are accessing this healthcare that you're providing.
So I'll provide a bit of a background on the healthcare space. I've been in the healthcare space for the past 16 years, and what we've seen is that you will get very few doctors in or practitioners in the rural areas, and you get more in the urban areas. That where are people concentrated on? For instance, in Kenya, almost 60% of the population is in the rural areas. The rest is in urban and peri-urban areas, but most of the people are in the rural areas, where if you compare the ratio of what WHO requires, nurse per patients or per population, or doctors per population, etc., you'll get that the distribution for instance, for Kenya, where we started from, is very low. It's really wanting. And then you go further down, if you now break that down from the urban area and the rural areas are really suffering. So we looked at the various telehealth platforms that were there, and we deliberately decided to do something a bit different. Reason being, we wanted to reach the masses, and the masses are the people who are in the rural communities, and also what we call the slums or slum dwellers, etc. So these are the target markets that we have majorly. And when you also look at telehealth now, telehealth is just consulting using any form of medium, yeah, without actually having a physical consultation. But if you look at audio, audio will give you up to 50% of a diagnosis. Most of the time, as a practitioner, you will talk to a patient. 70% of the history will give you, or 70% of the time you will get the diagnosis if you actually take the history correctly, if you document it correctly. And then when you go to video, with video, you're able to actually use the camera as a tool for physical examination. It's a subjective physical examination, but if you know how to use it well, then you end up having more. You have up to 70, almost 80% of the diagnosis, because you're seeing if I have a rash in the throat, if I have a swelling in the mouth, if I have a rash on my skin, etc. And you can be able to see that person. So when you go to video, it becomes better. And we know that for the middle class, for instance, in Kenya, for most of the middle class, they will have a phone number of a practitioner that they've visited before. But because they've established that trust between themselves, they will call them and they will text them a prescription, and they will take the medication and become better. And this enables access or increases access. But how do you keep the medical record? With that, then it becomes very difficult to keep a medical record via text and such. So that's why we came up with our platform. Our platform is an application which is called SASA Doctor. We have both audio and video capabilities. And the audio capabilities, we are able to do it either through USSD, through just a regular phone call. The USSD is just to initiate the medical record to be entered. Then from there, you are giving access to the doctor your medical record. If you had a feature phone today and next month you have a smartphone, you still have the same medical record. It's one the same record. So we're trying to bring that medical record for the patient, because the information usually belongs to the patient. It doesn't belong to the facility. It belongs to the patient. If the patient decides to go to another facility or another doctor, there needs to be some element of continuity of care. Most of our countries do not have that. And we believe that even parts of Europe don't have a medical record that as robust as we have. And that's what we're trying to push to our fellow Kenyans.
Thank you so much. That's a deep dive into, the background, the mission, as well as, what you hope to achieve with this. I do want to ask you though. Obviously, you did not, wake up one day, regardless of your 16 years of experience in healthcare, and say, "I want to solve this problem in this particular way." There has to be a tie-in somewhere. And so, for those of the people who are listening to us, I want you to maybe take a step back and then introduce your background. How did you get interested in telehealth? Why even the approach, right, to this? Obviously, there are a lot of different, healthcare providers that are available in Kenya, and everyone is taking a different approach. We work with a number of them as well. But I want to understand what your background and how it connected to the mission that you're championing today, and what you especially hope to achieve in terms of clinical outcomes, or even in terms of societal outcomes from this mission that you're trying to pursue.
All right. So I started clinical medicine, and later went in and did medical education and became a lecturer. And just I've taught in other places, mid-level colleges for clinical medicine and nursing. And where all this started from was way back when I was doing my internship, where I worked under a certain doctor, I won't mention, and we helped create the first ever database in Kenya using MS Access of all doctors. Then after that, the other platform that came in, I worked on the side as I was working in other organizations, NGOs, and eventually I ended up at Kenya Airways. At Kenya Airways, we used to have what we call modified basic life support. And modified basic life support is taught to the crew so that when they're in the air, they're able to attend to some emergencies. And during this time, I used to, by then we didn't have clinicians or doctors going into the what we call the inner circle, where you're able to communicate directly to the aircraft. But I talked to people, and we realized that we were having a lot of diversions. And I went into the inner circle. Oh, you're able to talk to the aircraft directly. Okay, can I guide these guys so that we don't have any diversions? So at that time, there is now more interest that is coming up where I'm looking at, we are actually having an audio conversation and you are able to assist a client remotely, yeah, in the air. And then you have the patient landing, and then you take it over from there. And in some cases, most of the patients would arrive stable by then. So when I got this opportunity to work with SASA Doctor, we met with it's called Arifa Mlani and Shamila Kamali. Shamila is now not working with us. This is more of a silent co-founder. So we sat down and they wanted to do something for Kenya. And Arif is born in Uganda, but left Uganda as an Idi Amin refugee to Canada as a small boy. Shamila is born and raised in Kenya. Shamila is a medical doctor and works with WHO and the UN agencies in Pakistan and other places. And yes, they wanted to do something as a social enterprise in Kenya. And I gave in my ideas and they liked my ideas and we started working together. But the basic principle that I was trying to bring in for me is, yes, we can use a platform, but we need to keep a medical record. We need to audit that medical record because the patient knows themselves better than we do as practitioners. They listen to their bodies 24 hours. when they come to us as medical practitioners, they will tell you within 15, 20 minutes, they're trying to compress the information to you so that they're able to, you're able to decipher or determine what they're suffering from. So that was the first thing. The second bit is, if you look at our healthcare system, I'm sorry, I'm not going to throw shade, but we have a lot of overprescription and we have over testing because we have facilities and these facilities need to make money. So sometimes you just have to go a bit overboard. When I was working in the private sector, that is a norm. You're given a target, you have to meet it. So we decided to create a layer where the doctor is not incentivized to over test, is not incentivized to over prescribe. So they have to actually give what is necessary. And when you give what is necessary, when we were being trained, we were told to give what is necessary. But when you get out there, it changes all of a sudden. But the healthcare outcomes that comes out of overprescribing, especially over-testing, is just making most people not to be able to afford healthcare, becomes too expensive. Over prescription, yes, it might not cause anything, but in some cases, all medications are poisons. So over prescription, you're actually introducing something else, something foreign. If you're introducing something different, then you're going to have something else come up within the body. So we intentionally made that happen on our application. And the other thing we did is to ensure that our practitioners are properly trained. So I created a whole curriculum because I'm an educator myself. So I had to create a curriculum, what I call a telemedicine curriculum. I've been involved in making curriculums for medical education, for clinical medicine, for nursing in Kenya and some other countries. I've become part of the team. And I created this curriculum to retrain our practitioners on how to use the camera as a tool for medical examination. And in that, we created also processes that we ensure that these processes have to be followed, where, for instance, we look at the medical notes, we have case conferences, we have to look at how did you treat this patient? If this patient came to us today with this condition and returned after 5 days with the same condition, what did we miss? What is it that we missed? At that point in time, you are able to flag down a few things so that we are able to have a good continuity of care. And that now creates what we pride ourselves in being the family doctor. In as much as, so we did this research, and in as much as the people who have healthcare financing, they have insurance, etc. Most people don't have a family doctor. Over 90, almost 97% do not have a family doctor. But we pride ourselves and we tell people, make SASA doctor your family doctor. And we don't say you choose one doctor to become your family doctor, because it is a collaborative event to be able to treat a person. You need a nutritionist, you need a counselor, you have mental health issues, you have nutrition issues. Then you have the practitioner themselves. So for instance, a general practitioner. And then in some instances, we add in a pediatrician and a gynecologist. Now you're taking care of a family. You're ensuring that the common ailments that they will come to the hospital for can easily be taken care of. So this coordinated kind of care that we do is to ensure that we have good healthcare outcomes. This is where the quality is. And the last bit is being available on demand. So when we started, we had 0 patients, but we were operating 24 hours in 2018. We were always having a doctor on site. Initially, we decided we have to use doctors from their homes or their offices, but it didn't work. So we had to bring them on site in our clinic. They sit there, they see patients. Even if you call in the middle of the night, if you take your app today, right now, and you will be able to see at least a general practitioner, and then from there we are able to attend to you. So in short, when we build this, we said we are going to practice good medicine. And to practice good medicine, we wanted to follow only four pillars. And in these four pillars is number one is not overprescribing, number two is not over testing, number three is being available on demand, and then number four is the quality that we have brought in. Um, you will see in all our websites and such, we stand for quality, affordability, and accessibility. So if you have good quality healthcare that is affordable and accessible, then you are able to achieve some form of universal health coverage. But we've gone a bit further. We've now morphed, and then we looked at there is a piece that is usually missing. Most Kenyans or most Africans are one catastrophe away from being poor.
So, Doug,
One health.
before you drop that nugget, I actually want to stop and then ask Lucy. I know she's got a question on her mind, to bring in, and then there are a couple of questions that folks have sent in that I want to ask as well. But I don't want you to lose that thought about this piece around, Kenyans and then their behavior, and we're going to tackle that. But Lucy, I want you to get that question off of your mind that you want to ask.
Thanks. And thank you, Francis. You mentioned how important it is for the patients who text their doctor because of the relationship and that trust, and how that continuity of the relationship and the information is important. How does SASA Doctor help sort of capture that or convey that through its platform?
So, as I told you, right now I'm at the coast right now, and tomorrow I'm going to visit some fisher folks at Malindi, right at the beach. So what we do is we go to the clients. We know that Kenyans have a very weird way of accessing anything. So they have to gain that trust first. In that trust can only be gotten when you're doing something physical with them. Some of these people will go on Instagram, they will go on Facebook, and they will figure it out. But if you give them a platform like SASA Doctor, they will say it's very difficult to use. So what do? We go to the clients, we do medical camps, we do free wellness checks, some paid wellness checks. Once we do that, we provide a consultation, maybe with a general practitioner plus a nutritionist plus a counselor. You establish a relationship. Once you establish a relationship, that person will come to the platform and they will select the person that they saw on the ground. Once they utilize them once or twice, the third time they will try somebody else. And all of a sudden, they trust the platform. They trust that you're doing the right thing because they're getting better. That is the trust that you need to build. And we always go with this slogan is, it is not the touch, it is the trust that people have for the healthcare practitioner that makes them feel comfortable, and eventually they're able to get better. Because it all starts from the brain. If I don't trust you treating me on a platform, even physically, I don't think I will. But once you have established that trust, then you go online. It's very easy and straightforward. So that's what we're doing.
Yeah, thank you. And I'm sure having access to all that information across all of your teams help patients to trust not just the one doctor they see, but then the rest of the team.
Yeah, so for instance, when you go in as a team, they're seeing several people. For instance, we are having this hearing testing, you're having a dental check for free, you're having an optical check for free, you're having a consultation, an actual consultation for free. At that time, if you had a problem, you want it followed up. So you know that the dental bit will be dealt by the dental person. The Hearing will be dealt by an ENT. Nutrition will be dealt by the nutritionist. So that is how people easily now relate to the coordinated care that they can easily get. So once they trust that, oh, all of you can speak to each other so that you give me an answer, yes, okay, this is really good, because we're looking at a future where we will have, for instance, we're using like right now StreamYard. On a consult, we will have 3 to 4 videos at the same time with the patient, another specialist, another, maybe with the mother working, a pediatrician here, a general practitioner here, and the nanny with the child. So at this level, you are able to have the pediatrician talk to the general practitioner, and they leave it to the general practitioner to move on with the management of the patient, and the mother was working, etc., etc. So we're looking at all these things to for the future, and these are things that we really wanted to start from the start. But some of these things don't work out as you want.
Thanks a lot, Francis. Thank you for that. Lucy, did you want to ask a follow-on question?
Yeah, I'm curious how many different types of specialists that you're able to bring onto your teams, and whether or not you find, because it's telemedicine, you can get more specialists all in one room that you might not if you were, going to the hospital or to the clinic.
I'll be honest with you. We've trained now over 1,000 practitioners to come onto our platform. Some of them don't make the cut because of the strict and straightforward what we want. We are upfront with what we want to see. We want to see good healthcare outcomes. So yes, you can get a lot of practitioners to come onto the platform, but not all of them stay. So far, we have most of the essential workers or the essential practitioners on our platform, including specialists. And then from there, we are still building up. So people are still not okay seeing patients virtually, not everyone, but we have several platforms, and we're seeing more and more practitioners coming on. The second bit is that we have some practitioners who have found it easy for them to use the platforms because it is, first, it might be extra income for them because maybe they are working in a remote rural area and they want to move to an urban area where they get the side gigs, what we call locums here. So now that person, instead of them moving from a rural area, moving to an urban area so that they can get more work, they just stay in the rural area and then they're able to get more work through the platform. So we're seeing more people who are in the rural areas come onto our platform than the people from the urban areas. But yes, we've been able to get a number of practitioners, and it becomes an on-demand service. When it is an on-demand service, I have a schedule for instance, if a pediatrician just comes on, most of the time a pediatrician will be on our platform. If you walk into any of the facilities in Kenya, you have to be scheduled maybe a day or a week later so that you're able to see that pediatrician or that gynecologist or whoever that is. So in this case, you're able to see them because they're able to work even late hours. They can work even in the evenings. So that helps get us more practitioners on board.
All right, ladies and gentlemen, if you're joining us at this time, we are speaking to Francis Osemo from SASA Doctor. He's a co-founder, CEO of SASA Doctor, a telehealth provider in Kenya, enabling accessibility and greater healthcare outcomes for the ordinary Kenyan through telehealth. We are also co-guesting today or co-hosting with Lucy Harshon, a global healthcare expert, who has focused on emerging healthcare, has led many wonderful initiatives, all focused on driving accessibility and greater financing ability for um, Africans as well as other other emerging markets around when it comes to the global healthcare outcomes that we're looking to achieve. Francis, there's a question that someone sent in that I wanted to ask you, and it comes from something that you touched on. Behavior and the way that people view telehealth, right, initially creates a barrier. You talked about the role of trust in helping people to access telehealth. And while it all seems great, it seems like very time consuming and as well as very involving initially to be able to uplift that. Um, if someone who's watching you today, right, as they are going to, living in the diaspora, is trying to consider, why should my mom um, be seeing a doctor from SASA Doctor? And, the background is the fact that SASA Doctor is one of our clinical partners for Fleri's membership program. We bring our beneficiaries to you primarily so you can assign your doctors as primary care physicians, giving this service or this ability for a family to actually have a personalized family doctor, someone that they go to as a center of all of their healthcare access on that end. For the person who's listening to you today, who is still weighing between, should my mom or should my aunt be, taking a matatu to the hospital, staying in line for 3, 4 hours just to see a real doctor in person. What do you say to allay these fears? What do you say to reassure them? And how do you want them to think about you?
First of all, we need to all realize that healthcare is a sensitive matter. And most of the time, we take it personal when it's being delivered to our loved ones. So why would you even consider using telehealth? Because it's convenient. If you look at the type of clientele that are using this, this is from my own experience, type of clientele that are using this are not young people. They're not young people. Our average age right now is around almost 40, 41 or 42 on our platform. Yeah, considering that is not considering children. We just remove the children. Anybody past the age of 18 and above. So the average or the median age becomes around 42. But there are also children there that lowers it down. But the people who are actually utilizing the services are the older generation because they have chronic conditions. They don't need to walk into a facility to get a refill. They need convenience. If I want to see a doctor to get a refill or to have my HbA1c planned for in the next 2 months, I don't need to walk into a facility. So behavior change starts from education. And whenever we do this sensitization or trainings, we actually educate people. We talk to them so that they understand. Once they understand, they easily come on board. And sometimes I've seen them use their grandchildren to navigate through the application. I've seen that happen. Why? Because they now have developed a trust to the system. Once they've developed the trust to the system, they know that they're going to get their medication on time, they're going to get their labs on time, they're going to get the actual information or factual information. In some instances, we have to use a practitioner that speaks their local language. The few elderly people that will not be able to speak Swahili or English, or they will have very little Swahili or English. But for you to go through them, for them to actually understand why you want them to take this medication in the morning, why you want them to come and pick medication from you, you have to educate them. You have to show them. So once you show them that education bit, then the uptake becomes easy. So for anybody who's watching, why would you choose this for your parents or your loved ones back home? It's one of the efficient ways, and you can easily work collaboratively with our practitioners and be able to have good healthcare outcomes. We are tracking these healthcare outcomes. We are ensuring that we we are delivering good quality healthcare. So because of that whole process that I explained earlier, most people would, I've seen people choose this for their family members. Why? Because they have understood. First, you have to understand. Then that buy-in comes in. Oh, actually, instead of my father going to a facility, pay 2,000 shillings for consultation, wait for 4 hours before seeing, or have the whole process take 4 hours. By the time they're living there, they're already stressed, and stress is not a good thing for some of these conditions. So you need to be able to take care of that bit. So that's why you should try and choose this. I hope I've been able to answer that question correctly.
Yeah, yeah, you definitely have. I think it's touched on some important points with regards to that. Lucy, did you have a question to follow that?
Yeah, so Francis, you've mentioned the curriculum that the providers on the platform take, and you've mentioned, the kind of tracking of outcomes. Can you tell us a little bit more, kind of drawing the line between those two, about how you ensure that all of the providers on your platform are really high quality and providing good care?
Um, as a trainer, it's really important to assess everything. So we do M&D throughout. For instance, if today you are seen on our platform, tomorrow you will get a call, a phone call from our customer service call center. They will ask how was the demeanor of the doctor, and they're being scored. We don't want the patient to score directly. I know they can score directly, you can have ratings, etc. But sometimes we don't get the true picture of what is happening because they will just put in a rating and that's it. In this case, you are asking specific questions. The call center will ask specific questions and get to know how was the experience of the patient. The third day, they will get another call from a general practitioner. And this general practitioner is asking, how are you doing today? Of how you've been taking the medication. With this medication, have you gotten any reactions, etc., etc. So there is the health bits that we're looking at. So in this case, you're able to easily get, by the third day, you easily get that this patient was not treated properly. By the third day, if the patient is not improving, we are having a problem. And if we see a pattern for a certain doctor, now we go in and we sit down, we find out what is happening. The other thing that we do, the medical record is available to the patient, and for select people in our organization, what we call the quality assurance team, will have this that they look at. And then we have flags on the back end. They'll be able to flag this diagnosis does not agree well with the medication that was given. The history maybe was scanty. It's not able to give us all this information. Because later we want to build an AI that will be able to predict clinical outcomes. We want to ensure that there is uh, assistance, clinical assistance for sort of what we call clinical decision making, assistance for clinical decision making. But it has to be documented properly. So if the doctor doesn't document, then they didn't do it. That's the rule. They didn't do it, or they didn't ask that question. So At this level is where we are looking at the quality of the practitioner. Do they actually know what they're doing, and are they doing it correctly? So we monitor this on a continuous basis. Every week, all patients are actually is a is a what we call it professional development for the practitioners. We don't get it called it's a case conference, for instance. Most facilities we use case conferences, but in this case we are discussing how would we have done this better, and then from there you are able to gauge this practitioner, is he worth or she worth to work with us. If you train them or retrain them twice, three times, and they don't do well, then we have a problem. Then we use the Kenyan clinical guidelines, and then we use the up-to-date guidelines. And then with that, we have the support of Dr. Shabila Kamali, and then we use the uh, Canadian College of Physicians guidelines to be able to gauge how our practitioners practicing their medicine. Um, I mentioned Canada a lot because we've borrowed a lot from Canada. The healthcare system in Canada is fascinating. They don't have a fancy universal health coverage, but it's working. You're using good quality generic molecules and you're giving people, and it's working, and all these things that we're looking at, it's actually working. This is the consistent way of doing things, and then we'll have a healthier population, and uh, a population that we can easily be proud of, because we will extend or we will increase the average age of Kenyans. So yeah.
Yeah, that's pretty fascinating that you talk about that. A couple of things that came in as questions that I want to ask before we move on to your actual products, right? Part of the reason why we're here, right? Talk about why the partnership with Fleri, right? For those who are joining us, and for those who do not know, Fleri as an organization is focused on helping immigrants in the diaspora better provide care in a more transparent, in a more accountable, and a more efficient manner for their loved ones living thousands of miles from them. Right? As a result of that, we partner with clinical partners, we partner with healthcare providers, providers of care packages and plans across emerging countries to make access to healthcare a lot more easy for the beneficiaries who live back home. Fleri partnered with Hughes specifically for the Kenyan market, but I want you to share your perspective on why say yes to the partnership, what you're looking to achieve with this partnership, and why you'd want someone who's paying attention, right, to access the benefits of SASA Doctor to Fleri.
Okay, I'll go back to what I said initially. Most people in Kenya live in the rural areas, and this is actual statistics. And most of these people who are living in the rural areas, in one way or the other, they have somebody out there in diaspora. And these are the people that go and queue in hospitals for a very long time. That said, they will actually call you in the diaspora and tell you, I have a bill of this much. Yeah, kindly sort it out for me. So why we said yes to Fleri, we work with other partners anyway, insurance companies, etc. But why we said yes to Fleri is we have a lot of people who don't know what is happening to their parents. How best do we get them to be able to have some element of visibility? Is by working with an organization just like Fleri to be able to bring the healthcare financing bit for their loved ones back at home at that point. That is the first bit. And then the second bit is the transparency. Remember, I talked about also the medical record. That medical record, yeah, if your father, my father would give me his medical record to look at and ask questions on his behalf if he doesn't understand. So in this case, you need just consent from your parent. And consent is them giving you the login credentials, and then you're able to look at it and question. This way, you don't have to be here to be able to take care of your parents. In most instances, if you go to our facilities, you'll get that a daughter has taken their father to hospital and they're asking for questions there and then. But you're not here. So why not work with a platform that will be able to bring you closer, because you'll be able to converse using a platform and you'll be able to get answers. So that's one of the things that we agreed to work with Fleri. The second thing, or the third thing that why we agreed to work with Fleri is we're looking at healthcare outcomes. And Fleri, according to the philosophy and what I've seen you doing in Nigeria, you're not focusing more on just the financing. There's the case management or care coordination that is involved. That is the one of the most important things that most people leave out. And this is why we said yes to Fleri.
I'm really, really glad that you clearly articulated that and could not have said it better myself. I think sometimes it's really important for people to understand the role that we play, but also the understanding that Fleri has no desire of duplicating the work that amazing physicians and healthcare providers are actually doing on the continent. And that's really, really important sometimes to be able to highlight. Because I speak to quite a number of people who have lived here a long time, are very educated, but somehow are still very ignorant about even the availability of quality care, right, in places like Nigeria or rural Kenya. And I think that's why it's important sometimes to hear from the people who are providing this care, to understand their motivations, to understand what drives them, as well as the outcomes that they're looking to achieve, right? Because that trust is critical, right? We could simply focus on the marketing message and tell you to buy these plans. But if fundamentally there is no credibility behind it, we will end up with a stuck audience. And that's part of the reason why we push for mediums like the Fleri Care Digest, so that when we send out these videos, when we put them on YouTube and we share them with groups and organizations, they're able to actually understand, oh, this is who runs this company. These are the doctors that they work with. This is what they're doing. Primarily because it's super important for people to be able to see that tangibly, right? Who is behind the care that my mom or my dad is going to be receiving on that end? And then before we go on to finally, what plans are you actually building? What are you bringing onto the Fleri platform? Talk about the services that people can access. I want to ask if Lucy has anything to ask or add on before you dive into talking about your care plans.
Not really a question, just more so to say that I think you articulated the exciting aspect of what I see of you guys' partnership around, the care management and that coordination piece for people's patients, but also to bring their families who are in other places in. So not so much a question, more to say, I think it sounds like a really fantastic offering and that a lot of Kenyans have a lot of benefit to take from SASA Doctor and their families who are part of the diaspora.
Great,
All right.
great. Yeah, Doc. So I'm gonna go ahead and let you talk about your plans, right? But while you do that, what I am doing on my end, and for those who are watching, they get a chance to see at least an overview of some of your healthcare packages that you have on, and we talked about all of this care that you're doing. How does that actually translate into products for the diaspora and for people who are thinking of their loved ones? I want you to talk about Tabibu Sasa, your UVC plan, the family plan, Nawiri, and then help people understand and connect the dots. Why are you doing this? And then what are the differences that exist? I'm going to try not to go too fast, but just at least as you talk to, help people understand where they can access this, where they can find this. As always, we repeat this every time. If you log on to www.joinfleri.com and you go to the services tab, you will be able to see all of the different care plans that providers are bringing on there. Once you do that, you can pick a provider or you can look under the Kenyan, plans, and you'll be able to see different providers. Choose SASA Doctor, and that will directly bring you to all of the plans that SASA Doctor is serving the diaspora with. So, Doc, I'll let you take that on.
So as I'm going, I won't talk about what is written here, but I will
Hmm.
talk about the product themselves and the
Yeah.
concept behind it. I'll start with
Yes.
the Tabibu Sasa UVC um, a bit. UVC is unlimited virtual consultations.
Hmm.
Why unlimited consultations? Unlimited virtual consultations, this is something that we came up with. Today, if you have Netflix in your house, either you use it or you don't use it, yeah, you have it. When you want to watch a movie, you have it, right? Most of us, our parents or ourselves, when we want to seek healthcare services, if you don't have insurance, if you don't have any other plan, you have to look for the money. So we made it affordable, so affordable for any person. If you have around $11, um, you have unlimited consultations to practitioners on our platform. If it is a family, that is an individual. If it is a family, it's around 33, 35 to $34 annually. And this is not a monthly rate, it's a yearly rate. Yeah, it's an annual rate. If you wanted to walk into a facility today, you will be paying for an individual consultation, probably you'll pay $20. But in this case, we're telling you for half the amount, you'll be able to get unlimited consultation throughout the year. That's the first thing. So when you go into this platform on Fleri, you'll be able to see all this Tabibu Sasa family and Tabibu Sasa individual. These two, the UVC individual and family, you're able to just purchase. This is just purely consultation. So we actually encourage people to utilize that. If they don't call us, we will call them. We'll want to find out how they're doing because of this plan. And then we have the
Hmm.
Nawiri Sasa program. The Nawiri Sasa program is a program that we take care of people with chronic diseases, where we are giving them nuggets, we are providing medication refills, reminders, trainings on how to use the medication, etc. And in some instances, if they control their, let's say, if it is a diabetic, they control their blood sugar nicely at the end of the year, they might receive a blood sugar, a glucometer from us. and then we train them on how to test themselves.
Mm-hmm.
These are simple, but now it is going to help us to increase the good healthcare outcomes. So that is for Nawiri Sasa. So Nawiri Sasa has the UVC component in it. You have the subscription, and then from there are able to do the care coordination for you and ensure that the patient is receiving medication on time. Usually, we deliver medication between 3 to 10 days before they run out. And then we have the outpatient comprehensive programs, as we call them, the Tabibu Sasa outpatient, blue, azure, and the other one. So
Mm-hmm.
these ones now include medications, labs, and diagnostics. Yeah, this is not insurance. It looks like insurance, but it's not insurance. It's a capitation model. But we use this now. We deliver the medication. We have labs in there. We have the consultation. Everything that we do includes unlimited virtual consultation. In
Mm-hmm.
whatever we do, our primary goal, you have to have unlimited virtual consultation. Then you have a cover of between 50, 100, 150,000 for, and we tier it down. There's a percentage for medication, percentage for labs, percentage for the consultation. But this is to ensure that we are not running an insurance company. We are a healthcare provider. It is considered a prepayment for services. You've
Mm-hmm.
already paid for these services, hoping that
Yeah.
they will utilize them. If you've taken a smaller risk for a higher risk.
Okay. Okay. Doc, could you talk about, you know, what makes your products different compared to, and I don't want to name names, compared to some of the other products on the market, right? Because, it's also important that as much as Fleri drives transparency, it also means that folks have choice, right? Um, People can transparently see different providers that are offering comprehensive care plans, just like what you are. But as they listen to this, as they watch you specifically speak about your product suite, I want you to talk a little bit about what makes the product that you're creating different, and why should people give that product a good try?
So the product that we offer is basically we're looking at what we call our USP, a unique service proposition.
Mm,
Yeah, there's several people who are trying to offer some of these things. Um, Fortunately, we've been the first to offer, and if somebody replicates whatever you're doing, then you're doing it right. So um, our unique service proposition usually is based that good healthcare outcomes comes or are achieved when people have a regular family available doctor. So we are not just a platform, and we are not just telling you to pay for something that we are not going to provide. Our platform is not just to bring doctors and patients together and they consult and they go their way. We have a vested interests in the good healthcare outcomes of this patient, because once they have a good experience, once there is a good healthcare outcome, yeah, it means we are vested in their good health. Tomorrow we will come and just pay. I want to just safeguard my parents. I just want to safeguard my parents. So that's basically why we have done this and the way we've done this. Yeah, others, I will not speak about other people, but we know that we are unique. Yeah, the fact that we've been the best telemedicine in over 2 years in a row, it means we've done something correctly. The fact that we have all major Kenyan insurance companies working with us, it means we're doing something right. It's not just connect patients with doctor and that's it. You're giving unlimited consultation. This product enables that person not to be thinking, you know what, I'm having a chest pain. Sometimes you get calls, yeah, for people who have the unlimited virtual consultation. They will just call. Doc, by the way, they will call the call center and then they will say, I want to talk to a doctor right now. And, and they will say, I am not sick, I just want to clarify something. Oh, yesterday I went somewhere, I ate something and I'm not feeling so well. Should I be worried? What does that mean? That person is really comfortable that they will get good advice. They will not just walk in into a pharmacy and they get a myriad of medication. At the end of the day, what happens? Good healthcare outcomes. But we cannot do that without some element of financing. Healthcare financing is the backbone of the outcome. So that financing bit, we've made it so affordable such that anybody can be able to access.
Doc, I really, really appreciate you. And then on that note, I think everyone knows that with healthcare, you get what you pay for, right? And emerging market healthcare is no different. In fact, it becomes even more critical to be able to provide the kind of services that you do, given um, how much of a need exists and also how few people have a history of their own health at their fingertips. Um, I'll let Lucy give her closing remarks on that end before we wrap up on that side. Lucy, any questions, anything that you want to add before we wrap up today?
Only thing to add is that I wish I'd had known about SASA Doctor when I was in Kenya last summer. You would have saved me a trip for an ear infection. Thank you so much, Francis, for sharing all of this with us. I think it's really exciting, and you're offering something that sounds hugely valuable to all of your Kenyan customers. So thank you for allowing me to be on here and asking you some questions today.
Thank you very much for hosting me and looking forward for more interactions. And I'm hoping that people will trust us, will take care of their families. And if we fail, then you can take us to, or you can hold us accountable because we want to be held accountable. You see, the way Netflix tells you there's this show you need to watch, we are those people. You need to check this, you need to do this, you need to ensure that you're eating healthy, you need to take care of your mental health, etc. So those are the kind of things that we do. Yeah.
Yeah. Doc, Francis, it's been such a pleasure having you on this episode. Speaking about telehealth, often can seem like a pie in the sky dream, especially when we talk about Africa and we talk about access to healthcare. I love the way you've broken everything down. I love the walkthrough of your product, but I also love the way that you closed. There's nothing like free healthcare. It's not possible. Um, there has to be value created, and that value has to be valued at something that has to be paid for. Um, we're extremely proud to be partnered with you, to be able to lean on the credibility and the track record that you've built in Kenya. And as we speak and connect more Kenyans in the diaspora to the work that you're doing, it is our goal to be able to drive that awareness and then drive, at the end of the day, the use and access to your own products on behalf of the folks that we're caring for back home. Lucy, thank you so much for being a co-host on this. Thank you for being so kind with your questions. Until we meet again in a couple of weeks, this has been episode 11 of the Fleri Care Digest. Our guest, Francis Osiemo, co-founder and CEO of SASA Doctor, a telehealth provider in Kenya, enabling access to healthcare and increasing the positive healthcare outcomes that Kenyans experience. Lucy Harshon has been my co-host on this particular episode. Um, you should check her out on LinkedIn. You should follow all of the work that she's doing. She's a global healthcare expert and consultant, primarily focusing on emerging market care. Thank you very much for this episode.
Thank you. Bye bye.
Bye bye.